So when we look at the data, AKI complicates about 5% of the hospital admissions, 30% admissions to ICUs, a big number. So epidemiology of AKI differs tremendously when we talk in terms of developed and developing countries. Why? Because of the demographics of the country, because of the geographical distribution, because of the comorbid disease economics. For example, if we talk of India, so India is now the diabetic capital of the world. So diabetic nephropathy of these patients, they are more prone to develop diabetic nephropathy. So that's why you have to look into it. So most AKI is reversible, kidney but being the most major organs, its ability to recover from complete loss of its function also. So AKI, but if it is not being treated and if it's progress, it can be a major cause of mortality and morbidity in hospital settings. So in large part due to serious nature of the illness that precipitate the AKI. So when we look at the etiological classification of the AKI, it is classified or divided into three main categories. The first is the pre-renal, then you have the intrinsic, and the third is the post-renal. And intrinsic is further divided into cause of glomerular, interstitial cause, tubular, and vascular cause. So these are the basic classification. When we look at the percentage, pre-renal AKI is almost around 55%, intrinsic is 40%, and post-renal is 5% of the total population. Now, when we look at the causes of pre-renal, which is the most common, 55%, it can be either due to intravascular volume depletion or it can be due to effective volume depletion from underfilling of the arterial circulation. So what can be the cause of volume depletion? If there is a hemorrhage, if there is a skin loss from sweat, GIT loss, renal loss, third space loss, if the patient is of burns, traumatized, pancreatitis, peritonitis. So these all can lead to fluid loss, volume depletion. But if arterial underfilling, why? Because of the reduced cardiac output, maybe due to cardiogenic shock, pulmonary embolism, pericardial effusion, or congestive heart failure. Or maybe peripheral vasodilatation because of the anaphylaxis, anesthesia, gram-negative sepsis, antihypertensive medications, cirrhosis, and other liver diseases. And the third is intrarenal hemodynamic changes. So if the patient is on, any renotoxic, maybe drugs that can hamper NSAIDs, COX-2 inhibitors, radiocontrast dye can also lead to, AKI, hypercalcemia, cyclosporin, or glomerular efferent arterial vasodilatation because of these ACE inhibitors or ARBs. So even ACE inhibitors and ARBs can lead to, their effect is, inhibition of the RAS, and because of this, there can be efferent arterial vasodilatation leading to kidney damage.